So I'm going to share my screen for a second. And normally, we kind of shy away from that, but just for this purpose, because I want this image to be understood very well. When we talk about resolutions of comorbidities, we are not talking about like some issue being maybe resolved, maybe not. The percentage of the resolution is extremely high. And so this is what I wanted to share with our audience so they can kind of actually see this. Now, when we look at, and I'm going to actually, 1 second, so there's my, right, so I'm going to use this guy here. All right. So when we look at type 2 diabetes, so this percentage is 83% of the time this is going to be resolved. So that's extremely high. So then I go to like sleep apnea, and 74 to 98% range, this issue will be resolved. So then we look at the cardiovascular, the third common one is 82%, and the hypertension is between 52 to 92%. So these are kind of like, we kind of now know them, but the percentage of the ratio of the resolution is extremely high in a positive way. But then we also see other problems here, right? So then, like I always talk about depression in our sessions with like many of our patients. They do need to get a site clearance because they do have depressions. Like the migraines, 57%. So let's see, the hypercholesteremia, like this is at 63%. The reflux is 72 to 98%. So, and the mortality, 89% reduction in 5-year mortality. So this is probably a doctor wrote this. I would probably write it in a different way, but it's not reduction of like, it's a good thing it's here. So you are actually improving someone's lifespan.
Yes.
So then quality of life improvement is 95%. So all these percentages, and I didn't make these up. So this is from I believe the NBAI, right? So this is the official document actually. So when we have this level, now I'm pretty sure many people don't really know this will be the result for them. So then I can see some of them who are not actually, that's why, like, as we always talk about, like the utilization of bariatric surgery, which is the most effective way of treating morbid obesity, is only 1%. So if I were to see this, and if I have the issue with morbid obesity, I probably I wouldn't think about it twice. But there's still some pushback from some patients, even from some practitioners. So they don't bring this up. So when I know that there is so much good out there for getting this problem taken care of, I have a little bit difficult time to understand why there would be that pushback. Anything you would like to say about that?
Of course. So, I mean, that diagram that you showed, Kamal, and I've always told you, is one of my favorite diagrams, right? It's from the Cleveland Clinic. And really what it shows is something very striking first, right? And that is there is almost no organ in the body that is not affected negatively by obesity, right? I mean, you're starting, when you mentioned migraine, Kamal, you're starting from the head, right?
Yeah.
And you're talking about gout, you're ending with the big toe of the foot, right? And then in between, you've gone through each organ system, and you've showed that obesity somehow is making all those organs diseased.
Yeah.
And what we're saying right now is, yes, you can do an itemized reduction of the illnesses by going to the doctor and say, okay, I'll get a pill for diabetes. I'm going to get a pill for high blood pressure. I'm going to get the CPAP machine for my sleep apnea. I'm going to get medication for reflux. I'm going to take medication for my arthritis. I may go for a knee replacement for my joints, right? So you are doing a plethora of interventions that, yes, by themselves, obviously can be taken care of, but as long as the engine of those diseases with obesity remains present and prevalent, even your individual approach is bound to fail, right? What is a good example of that, Kamal? A good example of that is the progression of hypertension and diabetes on somebody who remains morbidly obese, right? We always see in our case conferences, as you mentioned, a patient who actually may be already on medications for diabetes, and yet their A1C is going up, right? And why is that? Because their obesity is getting worse. So as the time passes, the diabetes will require more and more medication. So they may start, for instance, with their doctor telling them, okay, we'll give you this tablet for diabetes. Okay, now, a while later, they will say, okay, we have to add another medication. Now we have to add insulin, right? And when you're treating insulin, type 2 diabetes with insulin, you're not helping their weight, because with the insulin, the weight may go up as well, right? Similarly with the high blood pressure, right? You start with one medication, it's not enough. You go to an additional medication, it's not enough. Sometimes we see patients who have 3 or 4 medications for high blood pressure, right?
And they're usually not with the high blood pressure. So because of our other case conference, ACO, the clinical care side, I sometimes come to you, even though it's not bariatric patient, like PCP is managing 12 different medications. And because they have diabetes, hypertension, and let's say kidney, or diabetes, hypertension, and psych. So many, like it's so common these days, patient has 7 to 12 different medications. And then we
Absolutely. So if you look at all these diseases by themselves, Kamal, not only you're having a hard time controlling them by approaching them each individually, but also the consequences of those diseases by staying on that person are going to create even more problems, right? So if you have diabetes, which is not well controlled, you're going to end up damaging the kidneys, you're going to end up damaging the eyes, you're going to end up having problems with their feet and with wounds in their feet and with what we call neuropathy, which are problems related to the nervous system of their extremities, right? Same thing with high blood pressure. We talked about the fact that high blood pressure can cause stroke. High blood pressure can cause heart failure. High blood pressure can cause kidney failure. So you are progressing towards a situation where you cannot reverse those diseases any longer, right? So once you have kidney failure come out, that's it. I mean, the road ends there, because now we're talking about dialysis, now we're talking about potentially transplantation, right? And where is this road starting? This road that is taking that patient inexorably towards this irreversible situation. It's starting with obesity. That's why addressing obesity is important, because now there is not going to be fertile ground for diabetes to continue to progress, or for high blood pressure, or for heart disease. And of course, Kamal, talking about diseases, we have not talked about the big C here, cancer, right? We have shown now in many studies that obesity is a ground for development several types of cancers. Several types of cancers are actually much more common when there is obesity. So all these diseases are actually the reason why obesity also leads to an early death. I mean, earlier on in your talk, you mentioned about the reduction in mortality with bariatric surgery. If you look at the Swedish obesity study, Kamal, where they were able to follow 2 groups of people for almost 16 years, right? What these 2 groups of people had in common were they were all morbidly obese. But one group, about half, about 2,000 people, underwent bariatric surgery. The other group did not go under bariatric surgery, right? They followed them. Now, the mortality, the death rate in the group that was not treated with bariatric surgery was 30% higher, right? Which means that the diseases that develop with obesity, unless they are treated with weight reduction with bariatric surgery, will lead to an early death, not only to the presence of those chronic diseases, essentially.